across the world for new topics and for upcoming futuristic topics in healthcare, in the hospitals as well as in the laboratories. So today we have a highly recognized figure with us, Mr. Sten Westgard. So as from the name you all understand, Westgard is a very familiar word with the people who are working in laboratory. Westgard rules were founded by Mr. Sten's father, Mr. James Westgard, and you all know that these Westgard rules are important, integral part of the quality controls in the laboratory. So today we will be talking about role of Six Sigma in the laboratory practice, how the precision and accuracy of our results can further be improved with the help of Six Sigma. And before we move on to the topic, let me formally introduce Mr. Sten. Mr. Sten Westgard is Director of Client Services and Technology for Westgard QC. For more than 20 years, Mr. Westgard has managed the Westgard website, course portal and blog, creating and administering online trainings, as well as editing and writing hundreds of reports, essays, and applications on quality control, method validation, Six Sigma risk management, and other lab management topics. He has edited and contributed to numerous books on quality, including Basic QC Practices, Basic Method Validation, Six Sigma QC Design and Control, Six Sigma Risk Analysis, Clear Final Rules, Assuring the Right Quality Right, Poor Lab's Guide to the Regulations and Nothing But the Truth About Quality. Mr. Westgard is also an adjunct faculty member of Mayo Clinic School of Health Sciences in Rochester, Minnesota. Thank you, Mr. Westgard, for joining us today. And now I hand over the things to you. So over to you. You can carry on with your presentation.
All right. Thank you so much for that kind introduction, Dr. Jatinder. It's really a pleasure to be able to join everyone from KHO and to be able to share some additional thinking about quality to so many participants and labs in India. So today's topic is about trying to integrate Six Sigma not only into our laboratory operation, but really to show how they can clinically impact our patient care. As Dr. Jatinder was noting, there is an important disclosure to make. The Westgard rules that you know and maybe are frustrated by are the product of my father's work. He's known as the Westgard. Myself, I am the junior employee. I've only been working for about 27 years, where my father has been working for more than half a century. I run the Westgard websites. This is our primary way of reaching audiences, and it's something that's always available to you. It's the vast majority of our materials are completely free. We have a main website called westgard.com with more than 63,000 members. We have a blog where we do structured training for continuing education credits. And then we have a blog where we'll cover shorter articles and questions and answers. Our agenda today is to start by looking at how our lab results can impact patients. And really that's something we don't often make a connection to. We indirectly understand that the quality of our results impacts patients, but it's very rare that we have studies or any kind of measurable impacts that make us realize just how important a laboratory result is. Then moving from that observation, we're going to take a look at tools that help us improve and assess and redesign how our laboratory operates to help maximize the quality of our results. And there are 4 tools that we'll be looking at. The first will be the Six Sigma equation, which is quite simply, how do you place the performance of your tests on the Six Sigma scale? The second tool will be the method decision chart, and that's a graphic way to look at your performance. You can look at a whole instrument performance on a single chart. The third tool will be the OpSpecs chart. That's a design tool. It helps you redesign how you're going to run your QC. And that's where we end up finding opportunities to reduce the amount of expense and effort and time we put into performing quality control in the laboratory. And then the final tool I'll just briefly mention is called the Westgard Sigma rules. And it's, if you will, it's the most recent evolution of the Westgard rules. It just came out last August, and it integrates the Six Sigma tools into the Westgard rules. And it's really a very simplified but easy to implement version of all of these tools I've mentioned earlier. Finally, we'll look at how these tools can impact labs when they're put to use. We can use them to help us benchmark instruments all over the world in terms of performance. We can use them to assess how laboratories are performing, and then we can use them to improve our operations in the sense of saving money, saving labor hours, and saving the amount of resources we have to spend on operating an instrument. So I'm going to dive right in with the most complicated connection between laboratory quality and patient outcomes. I realize you cannot possibly read this particular slide. This is a poster. It's about 2 hospitals in Taiwan, and they did a healthcare economics outcome research study. So it's called a HEOR study. And they had 2 different scenarios. They wanted to look at their cardiovascular disease screening. How can they make sure that they correctly identify patients who are at risk of cardiovascular disease? So they focused on 3 different tests, and they looked at 2 different scenarios. I'm not going to tell you what the scenarios are at first, but under the different scenarios, they assessed what it cost to take care of that patient, how often the patient was misdiagnosed, and even what was the quality adjusted life years, or the QALYs, of the patient. Depending on the scenario, the lifespan of the patient would change. And what they found was, as imprecision and bias from the laboratory were combined, in the first scenario, 14% of the time, they would over or under treat the patient. Whereas if they went with the second scenario, there was a 10% gain in more accurate care. It was only 4% of the patients were over or under treated. In terms of the lifespan impact, in the first scenario, there were 131 life years lost per 1,000 patients. That is, patients lived shorter lives because of conditions in scenario A. Whereas in scenario B, statistically, there was no significant loss of life. There was no difference between what the statistics found and essentially 0. That is, in scenario B, the patients got to live every year, every month, every week, every day, every hour, every second of their potential lifespan. The laboratory had did not shorten the lifespan of the patients by anything significant. And then finally, the lifetime cost of care for the patient. Under the first scenario, it was 4 times more expensive. A 75% reduction in the lifetime cost of care was met if they went with scenario B. So obviously, scenario A seems like a pretty bad deal. You get worse diagnosis, patients don't live as long, and it's much more expensive to take care of that patient. Scenario B, you get better diagnosis, you get longer lifespan, and it's cheaper to take care of that patient. What's the difference between those 2 scenarios? Scenario A is when you have assays that are near Six Sigma. They are near world-class analytical quality. That's scenario B. And that's scenario B. Scenario A, the one that caused all of the problems, that was low quality. These were assays that had poor analytical quality of 3 sigma and worse. So obviously, if we can figure out what the sigma metric of our assay is, then that is going to impact our patients in multiple ways. It can lead to better diagnosis, it can lead to a longer lifespan, it can lead to a cheaper cost for the healthcare system. So it's one of those scenarios where if you choose high analytical quality, it's a win for everyone. It's a win for the healthcare system, it's a win for the patient, it's a win for the laboratory. Another study that came out also talked about the opposite, low quality, low QC skills. This was a lab in Singapore where their QC was not set correctly, and they had 5 tests out of control for 10 days. They released 63 results to patients during that 10-day period. They misdiagnosed 6 patients. 4 procedures were ordered, like MRI scans and CT scans, that were completely unnecessary. 7 patients had to be brought back in for retesting. And again, this is a scenario where low quality and poor quality control skills, so it's a combination of problems, end up impacting patients in a negative way. You misdiagnose them, it takes more expense, more time to treat them. If you had higher quality and better QC, none of this would necessarily happen. And here's a more telling point, is that this lab that made all the mistakes in QC and in patient care was nevertheless exemplary in terms of compliance. It had CAP accreditation, Joint Commission International accreditation. It even had ISO 15189. So on paper, they were compliant with everything that you could possibly be in compliance with. They were certified by everything. They were accredited to everything. And yet they still didn't understand the quality of their assays, and they didn't understand how to properly do QC. And that's actually a gap in our regulations. Our regulations, NABL, the 1112 document, does not actually tell us how to determine the analytical quality of our results, nor does it tell us what to do once we've figured out the analytical quality of our results. If you want to do those things, you have to go beyond the regulations, beyond NABL, beyond ISO 15189. You have to move into more advanced topics like Six Sigma. And in this particular scenario in Singapore, there was an additional contributing factor. It really was one of those worst case scenarios, perfect storm scenarios, where the lab was not doing its job with QC, but also the manufacturer was providing them a poor quality reagent. So a few months after Singapore published their bad patient outcomes, the Mayo Clinic in the US published their similar findings. And the Mayo Clinic, because it's such a high volume operation, they retrospectively realized they had given false positives, false diagnoses to more than 1,000 patients. 1,000 patients that they told, come back in now, we have to have another office visit, we have to have another set of tests, we may have to do more procedures, all based on laboratory errors. Again, the downstream impact of poor quality and poor quality control can be massive. Repeating a control, repeating a test within the lab is actually it's a really good deal. It's very cheap to fix the error once it's inside the lab. But if you let that error leave the lab, the expenses explode. They blow up in the healthcare system. If If you misdiagnose a patient, if you make them go to radiology and get an MRI when it's not necessary, that's a massive expense. So investing in quality in the lab is a long-term strategy for much more efficient operation. When we decide to adopt Six Sigma, the good news for the laboratory is we don't need to engage with the whole family of Six Sigma techniques. We don't have to get a consultant. We don't have to get green belts or black belts or master black belts, all of the paraphernalia and sort of the fad elements that belong to Six Sigma. What we just need to do is focus on defects. For every time you do a million things, every time you have a million outcomes, a million reportable results, how many of them are defective? You need to be able to count or estimate that. And once you do, you can put it on that scale of 0 to 6, that 0 to 6 sigma. And 6 sigma essentially tells us we have less than 4 false positives or false negatives out of a million reportable results. Almost defect-free. The low end, the floor on Six Sigma is generally considered 67,000 false positives or false negatives out of a million reportable results. Below 3 Sigma, when you're in manufacturing or industry or business, a below 3 Sigma process is too unstable, it's too expensive. You end up spending your time having to repeat the work, do it over again, come up with workarounds. You're constantly fighting this broken process. Within laboratories, I often see a 3 Sigma test can be easily identified by, it's a test where the techs are repeating controls often and recalibrating frequently and having to do a lot of troubleshooting and calling up their technical support line very frequently. And it's one of those tests where within the lab, it's known as, oh, this is one of those tough methods that we have to put up with, and we have to nurse it along. Those 3 Sigma methods, not only are they bad for patients, they're bad for the laboratory operation. They suck the time and money and effort out of your organization, and they can even demoralize the lab to the point where people stop paying attention to quality control results. They start repeating controls frequently. They start putting numbers out the door even when the Levy-Jennings chart says, actually, you're out of control and you should stop. When we move to applying Six Sigma to analytical testing, it's a bit of a unique situation, and we have to do a special approach where we calculate the Sigma metric. It's unusual. It's not like a lot of the other methods where we count the Sigma metric. Here we calculate it. And in order to calculate it, we need 3 variables. The first variable we need is going to be a performance specification, or you may think of it as a quality requirement. In terms of laboratories, we speak about it as a total allowable error. That's an error which can exist, but it's not big enough to change the diagnosis or the impact to the patient. So there's always a little bit of error in every test result that we have. Some of it is allowable because it won't change how we treat the patient. It won't change how the patient diagnoses. So we have specifications for the allowable total error. And if you exceed that allowable total error, that's when you're going to start with your false positives and your false negatives and your mistreatment of the patient. If you keep your error within the allowable total error, then the patient is going to get the right treatment. Now, these allowable total errors come from many different sources. In the US, we are directly regulated by the government. We have our CLIA goals. And for analytes that aren't directly regulated, then we have the CAP survey or other EQA surveys that set goals. And then around the world, there are other different sources. There's the RCPA, that's the Royal College of Pathologists of Australasia. There are, in Germany, there are the Rillibach goals. The European Federation of Laboratory Medicine has just put out a new biologic variation database. You can see a snapshot of the older one, and all of these resources are available to you for free. So if you're starting out with Sigmametrics, it's easy to figure out how good you need to be, because all you have to do is look that up. The next things that you need to do Sigmametrics, the fantastic part of it is you already have this data. Ever since you opened the doors on your laboratory, you've been measuring imprecision, you've been measuring bias. And those are the other two variables we need. They will help us figure out if we're actually hitting the target that we have set by establishing an allowable total error. So we use our daily control, imprecision, as our CV. And then in order to get bias, we have a couple different ways to get bias. We could do our proficiency testing or external quality assessment, EQA survey, could use that to determine our bias. We could use our peer group survey. If you belong to a peer group and you have a peer group mean, then you compare your own mean to it. That difference is your bias. And if you don't have either one of those, at the very least, you may have an assayed control. So there's a control that comes with an assayed or target mean, and then you have your own mean, and then again, that difference would be your bias. Any one of those ways to determine bias is going to be acceptable. So once you have the bias, once you have the CV, once you look up the allowable total error, then you have the three variables you need to calculate your sigma metric. So this is our first tool. This is our sigma metric equation. If you want to know how good your assay is, you take the allowable total error, subtract the absolute value of the bias, divide that by the CV. So it's your performance specification, subtract your inaccuracy or your trueness, if you will, and then you divide by your imprecision. The graphic is just to give you an idea of how the equation works. On either side, your allowable total error tells you this is the zone in which you need to keep all your results. If you go outside those two lines, you'll be generating false positives and false negatives. In the center is where our patient's true value is. This is really where their health status lays. We'd like to get that perfect answer, but of course we don't. There's an amount of error present in every measurement. The bias tells us we've actually shifted our results away from that true value. The CV tells us the spread of those test results. So if we know the shift and the spread, we know where the curve of the test result distribution is going to go. We know at which point it will exceed the allowable total error, and everything outside that allowable total error, those are the defects that we're generating. Here's a quick example of using that equation. This is from a 2014 study, Journal of Clinical Chemistry. We're looking at a cholesterol method. 3 levels were measured. They were using a 3-level control. They also did a comparison of methods against a reference method. They used a regression study to figure out the bias at 3 different levels. So we have our imprecision, we have our bias. Those are 2 of the 3 variables we need. What's the third variable? It's the allowable total error. How good does this test need to be? And currently in the US and in CLIA, and for any CAP lab and for any Joint Commission International lab, you have to be good within 10% of the true value. If you exceed that 10%, not only do they believe that's not good for patients, you're going to flunk your survey. You're eventually, at least in the US, you may lose your accreditation, you may lose your compliance, you will lose the revenue for that test. So we have our 3 numbers. In fact, we have 3 numbers at 3 levels. We can look at sigma metrics at the low end, at the high end, and somewhere in the middle. Here's the low end. We have our quality requirement of 10 minus the bias of 3 divided by the imprecision of 1. It's actually better than 6 sigma. In the middle of the range, our quality requirement of 10 minus the bias of 2.5 divided by an imprecision of less than 1. It's better than 6 sigma in the middle of the range. And it's also better at 6 sigma at the upper end of the range. And one of the things that you need to know about sigmametrics is choose one level that you think is most important for the interpretation of the test. That's our recommendation. But you are free to choose other ways to characterize your test. You may decide, I'm just going to take the lowest sigmametric, and that's how I will characterize that test. Or I'll average all of them. I'll take all the different levels, put them in an average, and that will be my overall assessment for this quality of the test. That's what we do at the lower end of the slide. You can see the average, and of course, because every level was above 6 sigma, even the average is above 6 sigma. I mean, what's the takeaway of all of those metrics? For this test, analytically, we believe there will be less than 4 false positives or false negatives out of 1 million reported results. This is a very reliable test. This is a test where you don't have to have a clinician repeat it multiple times to figure out what's going on with the patient. The first result will be definitive. And that particular example is coming from a very unique study. It came out a couple of years ago. It was looking at the 6 major diagnostic manufacturers and 8 common chemistry tests. And what they found, strikingly, was that there is no uniform amount of quality. Quality is not standardized. Quality is not a commodity. In fact, when you look at these different manufacturers, quality varies considerably. Now, I've blinded the manufacturer names. I don't want this particular presentation to be commercial. So I'm just showing you this data as a way of making you realize that you have to be sensitive. You have to investigate every instrument and every platform and every method. Never assume that anything you get is going to give you the requisite quality for patient testing. You must get the data, you must investigate and calculate and figure out, on this test, is the quality good enough for my patients? And for instance, so we were looking at our cholesterol example. Look at that top row. Across the board, you have one assay that is above 6 sigma. That was our example that we looked at. That's great news. But then the next manufacturer is below 3 sigma. And then the manufacturer after that is at 3 sigma. And the manufacturer after that is at 4. And the manufacturer after that is 5. So in other words, cholesterol, which we would think should be a commodity, is actually variable in quality across all the major manufacturers. You really need to take a hard look at your instruments before you purchase them and make sure the quality that you're going to get is going to be appropriate for patient care. And we can even use this particular approach to rank manufacturers. This can be very helpful when you're trying to decide what instrument to bring into your lab. No instrument is going to be perfect, but you would like an instrument that is better than others. So manufacturer E, out of 8 analytes measured, only 2 of them were market leading or 6 sigma performance. F, it actually doesn't matter because they're off market. Manufacturer D could get 3 of 8, C could get 3 of 7, B could get 4 of 7. And that 7 was simply because they didn't have enough data to collect for the 8th analyte. And then the top of the market, 6 assays were at 6 sigma out of the 8 analytes measured. So you can see between A and E, the top and the bottom of the market, 300% difference. That's a huge amount of variability in a marketplace. And we're only looking at 8 common chemistry tests. Now we're going to switch to our second tool. This is our method decision chart. This helps us visualize the performance of an entire instrument in a single graph. We take imprecision, we put that along your x-axis. We take bias, we put that along your y-axis. And your CV and bias essentially become x and y coordinates. And the diagonal lines, they create sigma zones. Near the graph's origin, that is world-class quality. 5 sigma is excellent, 4 sigma is good, 3 sigma is marginal quality, 2 sigma is poor quality, and less than 2 sigma, I hope you will think, is unacceptable. If that graph seems a little confusing, try and think of it more as the diagonal lines are like the rings of a target. You want to be close to that bullseye. In the bullseye, you have very few defects. You have much more confidence, or I should say, the clinician gets much more confidence in how they diagnose and treat the patient. But when you have more imprecision, when you have more bias, that's more false positives, more false negatives, more defects. That's noise you're putting around almost every result. And near the upper right of the graph, you're really going to confuse the clinician. You're not going to help them confirm a diagnosis. Just a side note, this particular graph, you can download it as a spreadsheet. It will plot the chart, it will plot your point, it will tell you your sigma metric. It's a free tool for you to use. Now I'm going to use this tool to walk through 3 different examples. Again, I'm not going to name these examples. The first one, it's just a chemistry analyzer. It's a Korean study of this where they looked at 2 levels of control. They did a bias comparison against a major diagnostic platform. So that's CV and bias. And then we use, in this case, I used the CLIA goals and said, take this instrument, put it in the US regulatory environment. Would it pass our quality standards? This is the method decision chart of that performance. So we have 26 different chemistry tests. We have a couple that are in the bullseye. So HDL and CK and potassium, they are in the bullseye. That's 6 sigma quality. That's good news. The other 23 tests are basically 3 sigma, 2 sigma, and much less than 1 sigma. And some of those assays, you can see how they're curiously tucked at the top edge of the graph. That is simply because there's no room on the slide. If I let those dots float up to where they should go, they're somewhere on top of the screen that you're looking at. They may be on the floor above you. The bias is immense. Again, that's really dangerous because either you have to keep the patient in the system longer while you baseline them and trend them, or you may get a complete misdiagnosis. Here's a study that's much closer to home for you. This is just published in March 2019 in a journal. It's an instrument, a major diagnostic instrument. This is in a hospital in Hyderabad, and you can see the sigma metrics are rather disappointing. They have a few bullseyes, few 6 sigma assays, but the majority of their performance is 2 sigma and less than 2 sigma. And some of those assays, now they're not off the chart in the vertical area, they're off the chart in the imprecision. Their imprecision actually moves off the chart, and they're so imprecise. Essentially, there's a lot of noise. There's a lot of noise, and you're really asking your patient to get sicker. In order to use this instrument effectively, your patients have to get sicker. So their sickness overcomes the noise of your methods. And again, of course, that means you're not going to catch their illnesses as quickly as possible because the noise of your instrument is going to overwhelm small signals. But just to give you an idea that it's not all bad news out there, this is a US instrument. It's a small hospital in California. 25 chemistry methods, essentially the same methods we were looking at earlier, but now 92% of them are at 5 and 6 sigma. So there's a huge variability in the marketplace. Some instruments do very, very well. There are a lot of instruments out there that do very, very poorly. You need the tools to be able to figure out which is which so you get the right instrument in your lab. Now, once you do, we're going to move on to our third tool. Understanding the sigma metric is nice. Knowing if I have an instrument out there that's a lot of bad sigma metrics, I don't want that in my lab. But what happens when I get an instrument in my lab, regardless of the quality that it is? How am I going to run QC? Now, NABL used to say, run one kind of Westgard rules on everything. NABL is changing that, and this is a tool that will help you keep up with the change in NABL regulations. Do enough QC that's necessary based on the performance of the test. That is, on a test-by-test basis, you have to determine the QC. Some tests will be poor and you need all the Westgard rules. Other tests will be fantastic and you won't need any Westgard rules. How will you determine this choice? The OpSpecs chart. This is a chart of operating specifications. It's set up like our earlier chart. You use imprecision along the x-axis, bias along the y-axis. CV and bias are your x and y coordinates, and you plot yourself somewhere on the chart. You can see diagonal lines. Those diagonal lines are really sigma zones. Think of them again as rings of the target. The closer you get to the target, the wider your limits will go. The fewer rules you will need. Even the fewer controls you will need to run. So right in the bullseye, in fact, you won't need the Westgard rules anymore. You'll just go to limits as wide as 3SD, maybe 2 controls. Your false rejection problem goes away. You see a lot fewer outliers. Of course, if you do have a lot of imprecision, if you do have a lot of bias, this tool will tell you the other result, which is you need to run more controls and you need more rules. You need all the Westgard rules, and your limits will get tighter because you need to use like 10x rules and 4-1s rules because there's more error, so you need more tools to try and detect those errors. And again, up in the upper right of that, on the upper right of the graph, QC will not save you. Westgards don't have enough rules to help you. Again, this is a free download. You can get that off our website. Here you can see one of the problems with a poor analyzer. You simply cannot run enough Westgard rules or run enough controls. There are 3 analytes in the bullseye where, yes, you don't need Westgard rules, but the other 23, you need all the Westgard rules. Here in Hyderabad, again, for most of these methods, you need Westgard rules, the full set, plus quadruple the amount of QC. Not 2 controls, not 4 controls. Really what you want, 8 controls per day. Now for most labs, well, that's clearly not affordable. That's really just giving you an indication that the instrument is not affordable. It's not that QC is expensive, the instrument is so expensive because the quality is so poor. Now, if you had the fortune to have a really good instrument, you would find out of the 25 methods here, 21 of them don't need Westgard rules. 2 of them only need 2 Westgard rules. And the worst assays, the magnesium and the calcium in yellow, they only need 4 Westgard rules. So here in this particular instrument, the 10x rule, it's extinct. You don't need to pay attention to the 10x rule anymore. There's nothing on this instrument that actually needs all the Westgard rules. And here's our final tool. This is actually sort of a very simplified set of instructions. It takes the standard Westgard rule flowchart, but it also imposes the 6 sigma zones. So you can see there are blue lines that break up the Westgard rules into sections. And it says 6 sigma and 5 sigma and 4 sigma and 3 sigma. So that gives you an idea. Figure out what your sigma is. It'll tell you how many Westgard rules you need to use. And below that, there's actually an additional recommendation that's just new from about a year ago. That tells you how often to run QC. At 6 sigma, conservatively, you only need to run your quality controls once every 1,000 patient samples. At 3 sigma, you should be running your QC about every 45 patient samples. That's a huge frequency increase. So obviously you want as many assays at 6 sigma as possible because your QC burden will go down very low. That again, you can download off the website. Now we've measured the outcomes of labs that have been implementing 6 sigma for almost a decade. Here you see one of the first labs. They started in 2010. they were able to reduce their costs by 45% in the area of control spending and the use of materials that would be consumed on the instrument while running controls. So that's $10,000 a year they don't have to send to the control vendor, $8,000 a year they don't have to send to the manufacturer of the diagnostic instrument. So that's $18,000. Put that at 10 years, or well, actually they're at year 9. So it's more than $160,000. That's a hard dollar savings. It's the kind of thing that your administration and your hospital is looking for. Show me you can cut costs. You can do that if you have the good instrument and then you do the QC design. What makes the lab much more happier than the hard dollar savings is the soft dollar savings. For this lab, it's an hour a day. There's an hour a day where their techs do not stand in front of the instrument. They're not repeating controls. They're not recalibrating. They're not troubleshooting. They're not on the technical support line. They're away from that instrument because the instrument is fine. And they can use that hour to do something that adds value to the lab. Run more tests instead of repeating a test. Figure out a new way to expand the operation, add to the menu. What could your lab do if you had thousands of extra hours? Because that's what this lab has. Over 9 years, this is thousands of extra hours they've been able to devote to other projects that increase the productivity of the lab. How do you get that extra hour a day? An 85% reduction in your outliers. That's how that OpSpecs chart or those Westgard Sigma rules help you. When you simplify your QC rules, you get a lot fewer outliers, thousands of fewer outliers. And we have duplicated this not only in the US, but also in Asia. So here's a lab in Malaysia, $9,000 savings every year in control costs, 250 hours they got back. Another lab in Taiwan. This is the lab that did the HEOR study that we saw at the early part of the presentation. So, you know, they figured out that this was great for patients and for the healthcare system, but within the lab, they also found out 85% reduction in their control costs, $50,000 a year they don't have to spend on control. And now they're in year 5. So that's $250,000 that they have saved in reduced QC costs. They keep this up, eventually their savings in control materials is going to pay for one of their instruments. And now it's 200 hours a year they've saved in troubleshooting. That's 1,000 hours of extra productivity that they've gained over the lifetime of this instrument. We have a global program that helps labs like the ones I just showed you implement Six Sigma. And we have a certain set of requirements. I won't really go into great detail here. You commit to using Sigma metrics, you adopt a standard set of global performance goals, you have quality managers go through training for proper QC and Six Sigma, and then we verify the performance of your assays. It's a 3-year commitment, so you have to say the first year we calculate Sigma metrics, the second year we optimize our QC, the third year we track how that changes our outcomes, how that impacts the rest of the lab. But when we combine all these efforts, we really believe you can get a higher level of quality and patient care in your laboratory and your hospital. There is a certificate for the verification of your data. Your individual quality managers will get personal certifications as well. We also collaborate and strongly encourage our VP labs to publish. So we've had multiple issues of different journals where we've had more than a dozen publications from VP labs. We've also aggregated data to do posters at AACC and ASCLS. So now let me wrap this all up. I know I have gone very quickly through a very large number of tools, but the main lesson is very simple. We need high quality to have better healthcare outcomes. And one of the best investments and the best bang for your buck is to invest in high analytical quality. We often neglect or make assumptions about the quality of our instruments. Our instruments vary quite a bit. We need to select the right instrument. We need to do the right QC on that instrument. And then that will help us figure out what's the right number of rules we have to implement, the right number of controls, even the right frequency of running those controls. And while we can make all of those efficiencies and savings, optimizations, we can also be confident we're going to support the right patient outcome. So that's what we can all get when we apply Six Sigma metrics. And at that point, I'm going to say thank you for your time, and let's open this up for questions. You may see at the very bottom, you see my email address. My father, or I should say my boss, mandatorily makes me include my email address at the end of every presentation because my job description, as he wrote it, is not just to present. That's not enough. My job is really to help labs all over the world implement these tools. And it would be a joy if I could be able to figure out your first Sigma metric, to redesign your first QC procedure, to help you track how this is going to change and improve the patient care at your hospital. Again, thank you, and now let's open this up for questions.
Yeah, thank you so much, Mr. Sten. I've got some questions. The first question is from Dr. Indranil Basu. She says that I'm getting to see that for level low QC, the sigma performance is less than 3. But for level high, it is showing more than 4. Then which to consider the sigma for that particular parameter?
That's a great question. It's very commonly encountered. Along the working range of a test, performance will vary, and particularly at the low end, if you push down near the lowest part of a reportable range of a test, your imprecision gets very high and your sigma will inevitably get very low. When you're looking at different sigma levels at different areas of your test, the question you want to ask yourself is, where are the patients? Where are the patients in their critical decisions being made? If it turns out, yes, at the low end, that is the most clinically important level. That's where the doctors make their diagnoses, change their therapies. Then the metric at that low end is the one that you should pay attention to. It could be at the high end, well, that control is so high, there really aren't any patients up there, and the performance is really clinically irrelevant, in which case you ignore that value. And so we typically try and recommend you have 2 levels or 3 levels of controls. Choose one that's the most important for that assay. Use that to determine how you think of that assay. So if it, use one level, if it says 6 Sigma at that level, consider that a 6 Sigma assay. Design your QC around a 6 Sigma assay.
So that means the level which is close to the cutoff of clinical decisions, that becomes the most important out of all the 3 levels.
Right, right.
Yeah. So there's another question, that is that as you told that with a good sigma, we can reduce the frequency of the quality controls. And especially you mentioned that for a 6 sigma parameter, even if we are doing QC, after 1,000 samples, it is good enough. But as per the guidelines, like we follow NABL guidelines, there are certain frequencies which are given. So what do you say? If we reduce the frequency according to 6 sigma, would that be acceptable by the accreditation bodies? Is it in India, or is it in America also, that we have to follow the guidelines of accreditation bodies, or we can go by the 6 sigma and explain them why the frequency is less?
The case of NABL is really interesting because the 1112 document that currently is on the books definitely has a mandated QC frequency, and it's blanket. It doesn't matter. NABL in that document doesn't care how often, how many samples you have or how good the assay is. There's just one rule. Now, I have seen the NABL document that's coming out. So the new version is not as stringent, but it does say if you're running a 24-hour operation, 2 levels in the morning and then 2 more levels throughout the rest of the day. So NABL is basically saying 4 controls if you're a 24-hour laboratory. Potentially, if in those 24 hours you were running just 1,000 patients and you had a 6 sigma, we might be saying you could get away with 2 levels. So 2 or 4, depending on who you're talking to. This comes up with a lot of local regulations. You're going to have to comply with the local regulator. Unless you believe in the appeal process, if they cite you for a nonconformance and then you bring the scientific evidence to your appeal, you have a good chance of winning. A lot of labs, they don't want any problems, they don't want any nonconformances, so they comply with regulators. Now, the QC frequency science is only 3 years old. We've only recently developed these options for QC frequency, and so inevitably the regulators are going to be behind. It's going to be several more years before regulators catch up and hopefully give you the flexibility of designing QC frequency based on the performance of the method. But typically every regulatory system does have a floor, and usually it's, well, in the US, CLIA says 2 levels once a day. Their 24-hour period, it could be a 24-hour lab, but you're still only running 2 controls. So NABL is doubling that. You have to do twice as much work here in India as you do in the US. I don't know why that is, but that's what NABL has decided to enforce. It's well-intentioned, but sometimes the math is going to tell us to get away with less. And eventually the science will inform the regulations.
Right. So I've just got a comment from Dr. Monica Gupta that the latest NABL 112 has left it to the lab to decide which tools to apply. So that means if with our sigma calculation, we can convince the assessors that yes, really that much frequency is not required. So we have a relevant evidence and we have a definitive answer that why we have reduced the number of controls. And you are very rightly saying that over a period of time, the acceptability by the assessors would also improve and the document would also change. There's another question from Dr. Deepika GS. How can we adapt 6 sigma for qualitative tests?
Oh, that's a very tough question. Yeah, in the abstract, so the 6 sigma process itself of just measuring how good a performance of any process is, you can do that on qualitative tests. That's possible. What I was talking about in this presentation was calculating. Because a qualitative test is just positive, negative, if that's really all there is, there's no numbers. We can't do a calculation. There's another approach called counting defects. And that's a little more traditional, actually, for 6 sigma. Just a moment. Having a little allergy cold here. In qualitative testing, if you get enough samples, so if you have enough patients running through where you can confirm the diagnosis, it's got to be a large number, it's got to be in the thousands, then you can count up how many times did I say positive when in fact it was negative, and vice versa. Those are your defects. And if you can count those and then put them over all the patient samples that you've gone through, that can be converted into a % error. So you have an error rate for your qualitative test. That can be converted into a defect per million rate, or a DPM rate. And then from that, there's a simple table that says, what is your DPM? This is your sigma metric. So you can qualify, you can characterize a qualitative test with a sigma metric. Now, once you know how good the assay is on a sigma scale, there's not a lot of impact. I mean, if you find out you have a low sigma metric for a qualitative test, it means you put more effort into it. But it's not the same kind of situation with our quantitative tests, where if we find out we have a high sigma metric, we reduce a whole bunch of effort. Qualitative testing, we weren't running Westgard rules. We weren't doing recalibrations and all this extra expense and time. So we don't get that savings if we switch to characterizing it on a Six Sigma basis. So Six Sigma can be done in a qualitative context. It's a different approach, and I'm not sure there are as many benefits downstream. Of course, the benefit of knowing that you're getting the right diagnosis, that's always good. So it could be a useful exercise to make sure, do I have a 3 sigma qualitative test, in which case I need to be more careful when I talk to clinicians, or do I have a 6 sigma qualitative test, in which case I can tell the clinicians, hey, you don't need to repeat this. The first result is telling you the right answer.
So they have to prepare their own data, and they have to calculate how many defects are there in their own data, and accordingly they have to benchmark it.
Right.
Great.
And the Six Sigma tables are everywhere. So, you know, we have one on our website, but any textbook on Six Sigma will have the table to help you make the conversion. They're all over the internet. You can Google and find one very easily.
Right. There's another question, that total allowable error, as you mentioned, that it can be taken from different guidelines. What do you suggest out of CLIA, CAP, RCPA, or what are the guidelines which should be usually adopted? Which are the lenient guidelines and which are very tough?
You know, that's a debate that is ongoing, and I actually expect this debate will never end, because as technology improves, as clinical diagnoses and treatments change, we will demand different levels of quality of our assays. In terms of what's a leading, I would say the majority of labs, maybe not the majority, but the largest number of labs are governed by US CLIA goals. So within the US, we're governed by CLIA. But if you think about the fact that CAP labs and Joint Commission International labs, those are outside the US, but they are governed by CLIA goals. So de facto, those goals really play a global role. That's my first point. Second point, very new information. Just a couple of weeks ago, the European Federation of Laboratory Medicine they launched a new website with biological variation database information that can be used to calculate more data-driven, scientific, evidence-based quality goals, allowable total errors. If you go to that website, allowable total errors aren't actually expressed, but all the data is there to calculate them. And those are thought of as, this is the most scientifically appropriate or scientifically pure. Let's say not appropriate, but let's say pure. The pure scientific approach would be to use those goals. Unfortunately, a lot of those goals are so small, no one can hit them. So we have some sort of scientific truth that EFLM is generating, but will be of no practical use for us for generations. So those might be in favor, but you have to really be careful and pick and choose, because some of those goals, there's a sodium goal that's less than 1%. And there's no method that can hit a less than 1% allowable total error. It doesn't exist. So, I mean, if you like to frustrate yourself, If you like to use way more controls than you can possibly afford, go to the EFLM, use their database. But otherwise, I would recommend looking at the CLIA goals. And then on our part, in our, I mentioned this Sigma program, we have looked at all the different resources and tried to choose the best of all of them. Not the easiest ones, not the hardest ones, but the ones that we feel are challenging but achievable, realistic. And so we're using on our program as a global benchmark. We have one set of goals we share with all labs. And so we have our own recommendations when it comes to choosing allowable total errors. Those are evolving. So every year we examine and we'll make some changes if we see there's really an opportunity to tighten the goal and not really throw the market into chaos.
So that's a very good information. So to summarize, I feel that Six Sigma has great advantage in choosing what kind of machine you should be choosing for your laboratory, reducing the frequency of quality controls, ultimately saving money on controls, on reagents, and on the manpower hours. So your time is saved, your reagent is saved, you can take the right machine, your repeats are not required to be done, your QC failures are low, and also there is a reduction in the false rejection.
Yes.
So with this, we finish today's webinar, and I once again thank Mr. Sten Westgard. Thank you very much for an elaborate and beautiful talk, and I'm sure that the participants or the listeners have been highly benefited with this talk, and we will continue and we will utilize your knowledge, and we will like that these webinars continue further on different topics. Thank you so much.
Thank you very much, Dr.
Thank you.
And thank you very much to all of CAHO for attending the webinar.